Hello and welcome to the show Beyond the Journal, where we discuss social media, digital education, and current controversies and open questions in cancer and medicine. I'm Dr. Jack West, Associate Clinical Professor in Medical Oncology at the City of Hope Cancer Center in the Los Angeles area. And I'm joined today by my co-host, Dr. Charu Aggarwal, who is the Leslie M. Heisler Associate Professor of Lung Cancer Excellence at the University of Pennsylvania's Abramson Cancer Center in Philadelphia. Hi, Charu.
Hi, Jack. Today we are pleased to welcome Dr. Mikkael Sekeres, who's the Chief of Division of Hematology, Professor of Medicine at the Sylvester Comprehensive Cancer Center at the University of Miami. Welcome, Mikkael.
Hey, everyone. How are you?
Good. So I wanted to start off by talking a little bit about your move from Cleveland to Miami. You wrote a really elegant piece in the JCO, the transplant. And moving is never easy, but I can't even imagine moving and interviewing in the midst of a global pandemic. I'm sure it had its challenges. I wonder if you can share what prompted the move, your process, and maybe our listeners will take some of it away as they may be contemplating a move in the near future.
Sure. Well, thank you for having me, and thanks for the question. Moves are complicated. We talked a little bit before we started recording this about our families, and it's not just a single person's decision. It involves a lot of people within our family, and then all the people we work with, and most importantly, our patients. So the ripple effects of a move can be just simply enormous. I started to think about a move. We're now in 2021, so right around the start of 2020. And I did it for a couple of reasons. First of all, I heard great things about Sylvester and the University of Miami. And I have always, for years and years and years, advised my mentees that you want to be pulled to a new position and not pushed to a new position. So the pull was there. And I kept hearing these really exciting things, a lot of places, everywhere from the ASH annual meeting to social media about the folks who were at Sylvester. It's no secret that people are moving to Sunbelt areas. So in Northeast Ohio, to be completely honest, the population is shrinking. So as you think about issues of maintaining your patient population, if you do clinical research, thinking about enrolling people to trials, if you do basic research, you're thinking about tissue samples, and honestly, the impact you can have in an area, if the population's shrinking, your impact is going to shrink, and the number of people you can serve is going to shrink. So that was part of it also. And we also talked a little bit before the camera started rolling about how as you age, I think you just simply become a little less tolerant of the cold. And I am in that camp. And as much as I loved living in Cleveland, I truly did. I mean, it almost sounds like the beginning to some bad joke, right? I love living in Cleveland for the year I spent there 1 week.
Yeah.
But I really did. It's a wonderful place to live. It has a great restaurant scene, great sports teams, and a great place to raise your kids. But the cold can be brutal, and those gray skies can be brutal. So I literally sat down with my wife as we were talking about a potential move with a map of the United States. And we said, okay, where is it that we would want to live? If we could choose anywhere, where would it be? And we circled cities around the United States. And then we said, okay, where is it that there are cancer centers that we want to be a part of, and circled those. And the Venn diagrams for those areas really settled on about 3 places. 2 of them were interviewing for division chiefs in hematology. So I interviewed at those 2 places, and things just moved along with Miami. Mm-hmm. Now, you'll recall I said that I started this in early 2020. So I actually went for in-person interviews in February of 2020. And as you recall the timeline, the country really shut down around March of 2020. So I had these great in-person interviews. Things really seemed to click for the position at Miami. And you leave a place and you just have a gut feeling about it. And I'm a big believer. Some people dismiss him as being kind of pop psyche, but I really like Malcolm Gladwell and his book Blink. And in that book, the basic premise is that our guts know a decision, the right answer, really sometimes within seconds of an encounter. And then we'll spend weeks, months, or even years trying to justify it logically because we're logical human beings, right? We want to bring some logic into our decision, but we really knew the decision right away. So I had kind of a blink moment when I interviewed at Miami. And over 2 days, I had 30 interviews. And during that time, you would think, oh my God, I must have been bedraggled in the smelly mess by the end of it. But in truth, I was more energized when I left than when I got there. And there were no cracks in the veneer. And I'm also a big believer that institutions will put their best foot forward on the interview day. So if it's a well-oiled machine and everybody's enthusiastic and high energy and seem happy, that's a really good sign. But if you go on an interview day and, they didn't send you the schedule until the night before, and then there wasn't somebody there to pick you up at the airport, and, a couple of people didn't make it to the interviews, it's probably a sign that there's trouble there as well. Right? And you're both kind of nodding and laughing. Like you've been to interviews like this, right?
Yeah. Yes.
Oh, yeah, totally. I mean, it just resonates in terms of, how the vibe is at a place, right? I think you can pick up on that pretty immediately. Are people happy? The people you're meeting with, do they display a love of what they do? Are they happy where they are? Are they thrilled to come in and interact with their colleagues? I mean, it's pretty clear, even from body language. People don't even have to say much sometimes. I completely agree. And that's why they're nodding.
It's like, if there's trouble on the honeymoon, it doesn't tend to get better after that. That's all, that's. Now,
wow, it sounds like a subject for another interview session, Jack.
It's a parallel. But anyway, and I've had a marriage. So, before. But anyway, let's talk about, you mentioned in the Venn diagram that this was a combination of the workplace and the city, the culture. And I grew up in Cleveland and withstood the jokes. They say there's 3 seasons in Cleveland: July, August, and winter. When I went off to college, they were joking about it as Detroit without the glitter, and that hurt too. But anyway, there's differences in the culture in Ohio and Florida, and the politics. I mean, right now, Florida's in the news a lot, and it's not always pretty. It's about, the political defiance of masks and vaccines. And while Ohio has a pretty diverse population and cultures as you move from north to south, Florida has a different feel than Cleveland, I would say. And, you have a son who's going off to school right now. And one of the big topics is whether anti-masks, whether masks as a mandate should be, are prohibited. And of course, I would say that the hospitals in Florida are, kind of known to be struggling with high volumes of folks with COVID. So has the culture been a shock or a real change for you, for your family, in moving from Cleveland to Miami? How much of an issue is the different vibe of a Cleveland versus Midwest versus Florida as its own socio-political setting?
It's a great question, and I could probably speak for 3 hours on this, right? We have Florida man as our governor. And people, I've heard people dismiss him as oh, he's such an idiot, but he's actually a very bright guy, which makes it even scarier. The policies he's put into place that thumb their nose at science, and frankly at the safety of the population of Florida.
Yeah,
and as physicians, I think we're naturally empathic people, and particularly as oncologists. we're naturally empathic people. So we try to understand things from someone else's perspective. And just as I'm sure both of you, as world famous lung cancer doctors, would never castigate one of your patients for being a smoker and then getting lung cancer. Similarly, as we're treating people who come into the hospital with COVID, we don't castigate them for choosing not to be vaccinated. And it's maddening, but it's also been so incredibly confusing. There's a great essay in Stat News by Jay Baruch where he talks about this, about what it's like to be the ER doc who's facing these folks who didn't get vaccinated and are on a lot of oxygen if they're seeing him in the ER and about to be intubated. And how does he navigate that kind of moral badlands of people making that decision? So right, the culture is very different where I am. So I'm in Miami-Dade County. Our school system decided to thumb its nose at the governor and mandated masks at the expense of the salaries of some administrators in the school, because that is actually what the governor said, that it's actually going to affect them personally, but they knew what the right thing was to do for our kids. So we do have that. I will tell you that I do go back and forth to Cleveland. And I find that masking in Miami people are pretty good about it for the most part, more so than what I saw in Ohio.
Really?
Yeah, it's interesting, right? You would have thought the opposite, but I'm also in an incredibly culturally diverse major city, right, where you have universities, you have major academic centers, and as much as there was a lot of controversy over how Miami-Dade voted in the last presidential election, people tend to lean left.
Yeah.
So there's that aspect of the culture. The culture of my patients is very different. I tell people when I was in Ohio, I saw farmers and factory workers. Those were the bulk of my patients. Most people who have acute leukemia don't have the time to go and search out, the best doctor for their diagnosis in the world according to some random ranking, right? So they just come. They come and come, and it's I always say leukemia doesn't read a tax return or a political affiliation. So I really got a cross section of Ohio. Here, I have a very different patient population. 50% of the patients we serve are Hispanic. So I see people from a lot of people who have some family origins in South America, who are Afro-Caribbean, who are Haitian, Cuban, which of course is very different than what I saw in Ohio. And I also see a lot of transplants from the Northeast, which is almost dichotomously opposite personality.
Can I just ask, do you speak Spanish? And if so, well? I mean, because that certainly would be something that would factor into my equation about moving there and how well equipped you would be.
Yeah, I think I have a congenital brain lesion and I am a hopeless monoglot. Like, for as much as I love words and language, I'm not very good at foreign languages. So I'm picking up Spanish, but I'm surrounded by people who are bilingual, which is wonderful.
Yes.
Because the translation is instantaneous and I don't even have to ask for it. But it's also completely inhibited me from learning as much Spanish as I could because people are jumping in to help my cluelessness.
Damn them all.
So, speaking of culture, there's been a lot of talk, and most recently on Twitter, really just bashing cultures on each coast, right? So the East Coast culture in academics has been viewed as very distinct from the West Coast culture, not just in academics, but not just in academic medicine, but also in general academics, otherwise as well. And, I know you've only been in Florida for a bit, but can you speak to cultural differences in what you've witnessed. You've been on the East Coast pretty much for your entire life before moving to Cleveland in terms of your training and residency, fellowship, etc. And Cleveland is more, I think, similar to the East Coast than dissimilar. But how is Florida been in terms of culture, and how's your experience been so far? Is it very different, the same? It is the East Coast, I'm aware of that. But how is it different?
It has a different feel to it. So I grew up on the East Coast. I was born in Rhode Island, went to school in Philadelphia, and did my postgraduate training in Boston. And then I went to Cleveland, which, I think every kid growing up on the East Coast says to him or herself, one day Cleveland.
Yes.
Actually, it never happens, right? So this was like pretty much out of the blue. But at the time, it was a great fit. I was, chomping at the bit to spread my wings and establish a career in leukemia and myelodysplastic syndromes, and had a lot of great ideas. And I joined Cleveland Clinic when it was the actual very first year it affiliated with Case Western and created a medical school.
Right.
And developed a comprehensive cancer center in collaboration with Case Western. So there were incredible academic aspirations at the time. So for me, that was a great move at that time of my career, straight out of fellowship, right? I also was in an environment where people were very supportive, and the culture was to move obstacles out of the way so that young people could thrive and build their careers. Oh my God, what a great place to be after your fellowship. So that culture was great. I had to learn to be a Midwesterner, and I had to learn two things. First, I had to learn to talk more slowly. And secondly, I discovered that I apparently have RBF. So I would walk through the hallways and people would say, is everything okay? You seem so upset. And I was like, no, I'm just not saying anything. So lack of smiling was perceived as being annoyed with things. So you learn, right? That was part of the culture that I figured out. And I really embraced it. I loved being in the Midwest. I used to teach some of my trainees that our coin of the realm is being nice. So people recognize you as being a nice Midwesterner, and it's a real thing. People were nice. When we decided to move down here, my wife is from the Pittsburgh area, and she's also a Midwesterner, right? Pittsburgh, people in rural Pittsburgh consider themselves Midwesterners. And she was really nervous about moving to the East Coast. In fact, it used to be a refrain. So here's the bias that you were talking about, right? If she was on the phone with some customer service person who wasn't getting anywhere, she'd hand me the phone and say, it's time for you to go East Coast on them and get what we want. So she was really nervous about it. We moved here, though, and people are so nice. And I know that kind of sounds like almost like a sales pitch. It isn't. It's some combination of having adequate levels of vitamin D, right? People are actually happier. And I think it's the Latin culture where people are genuinely expressive and warmer towards each other. I heard one person say there were going to be more deaths from COVID among Latin Americans in Miami, not from getting sick from the virus, but because they couldn't hug each other anymore. So it's kind of been like this refreshing welcome, and that's carried forward. That's the good part about being in a place in Miami. The other part of it is that one of my very good colleagues, Ken Figueroa, who's a wonderful translational researcher, Ken is a she, it's actually Maria Ken Figueroa, said to me that Miami is the most organized city in South America. It's funny, right?
Yeah.
So, things sometimes run on Miami time.
Yeah. Now, I wanted to ask, and I should clarify, I think that Cleveland has a very good reputation in the medical community. It's very strong for cardiology and oncology and, many things. So I think for all the, jokes and tropes about that, it's to people who love classical music or art or something like that, it's got a particular appeal. But that said, it sometimes is challenging going back to visit my family in the wintertime. But getting back to some of the challenges, you work in a field, we're all oncologists and we all have patients who are immunosuppressed, but leukemia is a bigger challenge and stem cell transplants a bigger issue with with immune suppression and risk, and potentially the need for significant hospitalization for the induction, for complications, etc. Have you had issues yet with there not being enough room at the inn because of COVID, for instance, or, specifically for that, and that encroaching on the wards that you need to do your work? And is that a concern for you, your colleagues who are heme malignancy specialists, and for patients?
Yeah, it's a fabulous question. There have been a lot of issues around the virus and people who have hematological malignancies, and specifically leukemia. So when this first hit, when COVID first hit, I have told the story in the past about one patient I eventually saw in the hospital who initially presented to the emergency room with symptoms of leukemia, which, guess what, are very similar to symptoms of COVID. So rather than get a CBC, they immediately rushed her to the COVID isolation unit, and at the time got a test that took 2 days to come back, and it was negative, and finally got a CBC when she was diagnosed with her acute leukemia. And actually came to us very, very sick, and eventually it went almost straight to the intensive care unit, which probably could have been avoided if her leukemia had been detected a couple days earlier. Yes or no? It's hard, retrospectively, it's very hard to tell. So that was one issue, is that people weren't being diagnosed. Usually, I kind of always joke we had a run of older adults diagnosed with leukemia right around the end of January, because generally their families saw them around the holidays and said, "You look like hell, you got to go to a doctor and get your blood counts checked." They would have their blood counts checked. That would lead to a bone marrow biopsy. In late January, we had this rush of people, older adults who had leukemia, that were diagnosed. We didn't see that. So there were, I'm convinced there were delays in diagnosis as well. Sometimes of these, more smoldering acute leukemias that we see in older adults, where it's a slow, slippery slide from myelodysplastic syndrome. Yeah. I've seen more patients, the inn will usually make room for somebody with a new acute leukemia diagnosis.
Yeah, but that's probably at the top of the list.
At the top, right? And it is. It's a medical urgency or emergency. So we can usually get them in. The issue has been more that I think the medical profession as a whole has been more aggressive about treating these patients as outpatients to try to avoid the hospital altogether. So I've seen a lot more post-remission therapy that ordinarily we would give as an inpatient, given as an outpatient, discharges from the hospital that are earlier than ordinarily we would do. And that in part is to make room at the hospital, in part because we want to expose our patients as little as possible to a hospital where the cold, ugly, hard truth is that hospital staff also were getting COVID and giving it to patients. And also because our patients were so desperately lonely because they couldn't have visitors. Right. So we had a lot of people, more than you would have predicted, who got really depressed and just said, "You know what, get me out of here. I want to see my family."
Can I ask, as just a related follow-up to that, we've all adapted to using telemedicine to some extent in the pandemic, and I would say that one potential use to shore up the really significant needs with patients with heme malignancies who are coming in very frequently, blood checks, but I think they do need a lot of points of contact. Has that been something that you have been using? I mean, you're somebody who's extremely connected to your patients, I believe, and not just on a medical basis, but interpersonally, and some of it's out of need. And so have you been able to use that practically? And, has this been an effective tool, or is it just not serving your needs?
Honestly, I can't stand it.
Okay.
So
that's why
I very reluctantly used it occasionally.
Okay.
My patients have to have their blood counts checked. Mm-hmm. My seeing a patient without blood counts is like a day without sunshine. It's my business. It's what I do. I check blood counts and I interact with people and assess their functional level and examine them and decide on therapies. But those blood counts are crucial. So since my patients have to come in anyway for a blood count, regardless of where that is, I'd rather they come into a main center where everyone's been trained rigorously in how to appropriately wear PPE than go to a community lab where I don't know what the training is. I think they're safer coming in. And if they're going to come in for a lab check, why the heck not just come and see me?
Yep.
Right? So I are on that side. I worry about how much we miss through telemedicine, particularly my patient population, where my typical age for my patient is probably around 70. I really want to see how they're functioning.
Yep.
And I don't feel comfortable that I'm picking that up 100% by seeing them from the shoulders up.
Okay.
So we're going to change topics a little bit, and I want to focus on writing. This is something you're clearly passionate about. It's you're really good at it, and I always wonder how you're able to, succeed academically, have a really thriving family, successfully raising a family, and also writing. So tell us how you do it.
I was hoping you were going to tell me.
Well, now in particular, I think I would love to know your background, because we all write, but there are a few who write as artfully as you. I think you write literature about medicine. And so I would love to know, because were you an English major? Were you an aspiring writer? Because you don't write like a doctor who just happens to write some columns on the side.
So you both are being way too kind, and you lie like big dogs. And I only hope my mom sees this, so it'll change her impression of me.
Link, yeah.
Writing, boy. Well, it's kind of my family business. My dad was a newspaper reporter. He worked for the Providence Journal-Bulletin in Rhode Island and was a reporter on politics for 20 years and then an editor for another 10. My mom was an English major. She taught English actually in a high school for a period of time as well. So I come from a family of liberal arts majors, and I've always had this kind of theory that I probably think about science differently than people I would think are true science-minded. I do it all through stories. All of science to me is a story, just like all of our interactions with patients are stories, because medicine at its core is storytelling. A patient comes in and tells the story of illness. We then hear that story and tell it to our colleagues, and we'll tell the story to a consultant who comes back and tells us another story until that story makes sense and we can figure out a solution. So I've always seen the two as kind of, there's no hard line between where like the science part of medicine ends and the storytelling and art part of medicine begins. It's fluid. Maybe that's just the way my brain works. I've been writing since, my family tells the story that I would write, I'd make up stories that, and type them out on my dad's old manual typewriter at the age of like 7. So some people come to me and they'll say, well, how do you get something into like JCO's Art of Oncology? You don't just wake up one day and decide you're a writer. It's something you work on for your entire life. When I was in high school and college, I was an editor on the literary magazines. I took writing classes while I was in medical school, and then continued to do it during residency. I journaled during residency, and I would flip back and forth between poetry and prose. So I actually wound up doing a lot of poetry when I was in residency, and then fellowship switched back to prose. And I think this is controversial. I think that our training knocks some of the humanity out of us, and then we recover it a few years into being faculty, and we remember what brought us into medicine to start with. So a few years into being faculty, I remembered that I liked to write, and started to do that. And for me, it's a way of processing the waterfall of humanity that we're seeing. And my stories always start at a place of tension. So if I walk into a patient's room and come out of that room and my stomach kind of does this twist, then I think, oh boy, there's something that happened there that I don't understand, and I'd better figure out how to understand it, because I don't want it. I want to make sure that my interactions with my patients are pure, and that I'm not bringing my own biases into those interactions. And something didn't go quite right there, and I need to figure out what it is. And that's always my starting point in a story. And then I work good literature. We always start in the middle and work backwards and then forwards. So then I work backwards to try to figure out what it was that led to that interaction, and then forwards to try to figure out a resolution. But like you said, we all write. So how do you write? I mean, every single day we write a progress note, it's a story. Or we're writing a review article or a piece of original research we're writing. So how do you write? How do you face the blank page?
Mostly smart phrases. No, just I think I am happy with how I express myself, more or less. And don't mean to be fawning. I just think that there are certain people who write in just such a literary way. It betrays a training and thought process of how to express yourself that's different from somebody who is more used to writing in a passive voice, third person, in a clinical way. And I don't mean that as a knock on anybody. It's just that there are people who you think, well, I could do that. And your writing to me is like watching, I don't mean to embarrass you. It's just like watching somebody who's really good at music or dance do what they do and think, God bless them. I'm just really impressed by that. I can't do that. And I just, and it's fine. I just really appreciate a job well done by someone who's very good at their craft.
Well, you're a sweetheart to say that. I think we each have things that we probably take for granted that we're exquisitely good at. And I'm sure there are areas of medicine that you far outshine me. If I were in the trenches watching you do it every single day.
Yeah, let's talk about how great I am. No,
no, I'm serious.
Can I just ask also about, there's many platforms for writing, and you write in a column short story format and for the masses with in things like, well, JCO in a way, or New York Times. Are there particular kind of people you think of as your audience? Is it largely just the lay public at large? Is it largely your fellow oncologists? Or is there some concept of who you think of that you're trying to reach when you put pen to paper or type it out?
Yeah, I love that question. And I love it because it gets to the core of, I think, how we talk to trainees about writing and about research and about anything that they're going to do that involves, I would say, putting pen to paper, but we don't do that anymore. Pushing key to keyboard.
It just doesn't sound as good, No.
But the first step is to know your audience, right? And to know what the standard format is for a journal. So if I'm writing a piece for Art of Oncology, for example, I know that my audience are oncology doctors, nurses, pharmacists, right? It's not just doctors, nurses, pharmacists. And other social workers, family members of these folks who are in healthcare. And so I know it's going to be on an oncology topic. It's rule one, right? If it's not on an oncology topic, it probably shouldn't go into JCO. Rule two is to know the length of a typical JCO Art of Oncology essay. And that's going to be around 1,500 words. So if you submit something that's 300 words, it's probably not right. Or if you submit something that's 4,000 words, I don't want to be the one reviewing that because it's a long piece. It's going to take a lot of work. So if it's something that's for the lay press, op-ed pieces are typically around 1,000 words. Some of the pieces I've written for the Times, I shoot for about 750 words. And again, you're modulating depending on your audience. Someone who reads the New York Times is a layperson, but they're usually a pretty sophisticated layperson. I don't have to go into the 6th grade reading level. And the key to it is pieces of writing should educate and entertain. So I always keep that in mind. That's really what I keep in mind. I mean, I got to have a sense of my audience, but if I'm not writing something that's either teaching something, even if it's something totally random, like, the origin of daunorubicin, right? Even if it's just a little snippet and someone learns it, they're like, I didn't know that. That educated. Mm-hmm. Or entertains. And that entertaining could be something that's funny, something that's poignant, or something that resonates with a commonality of experience. So when I'm writing, I'm assuming that my audience is going to be wide, just because you'd be surprised that people who read pieces everywhere from JCO to the New York Times or Huffington Post. You just never know. I probably oversimplify my language and probably do it so that I don't have to modulate it depending on the audience. So I don't use as many complicated medical terms if I'm speaking to doctors or if I'm speaking to patients.
No, it's great. Sounds like you have it all sort of distilled into a science. Yeah.
It's
hard, but it's really, also,
It's really insightful because there are rules to writing. And if you just stick to those rules, pieces tend to come out okay. So for example, the whole thing about starting in the middle and working backwards and forwards, that's a rule. Or I have a rule, I'm not allowed to repeat the same word in the same paragraph. Because the more you repeat the same word, the more boring it gets.
Right. That's great. You've been very involved with ASH. That's not a meeting that, or the annual meeting of ASH is something that I have not attended in a long time, and I doubt Jack has either. We've really drastically changed how we absorb new information in medicine over the last few years anyway, with social media and technology, et cetera, but more so, I think, within the last 18 months with virtual meetings. How has it been with ASH? And is there a move towards hybrid meetings in the future? Or do you think everything will go back to how it was? What are some of your predictions, and what are you discussing within your group of hematologists?
Especially since you are dealing with such an immunocompromised population, I don't know if that's a greater concern.
Yeah. So I really love that question, particularly in the context of each of us Zooming from someplace that looks like it's not the hospital. So if 5 years ago, would we have done this, or would we all have been in our office?
Totally. We would have been in our office. Yeah, totally.
Right. And we can say that it's because, Delta is surging and all that, but I think things have changed for us. And I think there's more of an acceptance of, people, the value of working in different spaces, and how I personally think that keeps me more engaged in what I'm doing, to know that I'm going to have different environments. I think meetings are going to be hybrids. I don't see how we could go back to everything being in person again. And there's been this incredible benefit to having virtual meetings. And I'll give you an example. I co-chair European School of Hematology meeting on myelodysplastic syndromes that takes place in the south of France in Montpellier. And I co-chaired it in person about 2 or 3 years ago, and about, 500 people showed up, which was a good show up. It was a nice, beautiful area, great meeting, high science. It was wonderful. We did it virtually in January, and 2,100 people showed up virtually from over 100 countries. Wow. Right? What an impact. How many people were we reaching with these same great scientific presentations? But I didn't get to see the coast, or, go in to see in Monte Carlo, the casino where James Bond was filmed. That's true. I missed out on that. But the science and the education were there. So I think that's here to stay. I think we have to establish what the value added is of being in person. And it's not going to be the quality of the talks. I think we give good talks over Zoom. I think more it's going to be the nature of collaborations.
And I also think, you say, well, it's impressive that we're talking today from home offices, but we probably wouldn't be talking today if it weren't, it's not like if the alternative was coming together in the same room, we wouldn't have this. And it's, easy to do this now. I think we have to weigh the incremental value of a live meeting against all the people who couldn't come to the live meeting. I mean, when we think about ASCO or ASH or all the people who might be prohibited by cost and time and infectious risks and things like that, it's equitable to have something like this, and there are trade-offs. So, I just think I think there will always be a value to interacting in person, but it's not just some poor consolation prize to have this kind of interaction.
I totally agree. Do you think that ASCO, which is the ASCO annual meeting, which is even bigger, so ASH annual meeting has about 30,000 people. The ASCO annual meeting probably comes closer to about 45,000 people?
Mm-hmm. That's exactly right.
So how do you think that's ever going to go back to fully live with no virtual?
No.
I don't think fully live without a hybrid component is ever going to be possible now. I think the reach, as you said, the ability to reach an international audience without having to travel to be able to get the same content, I think is just huge. And we're becoming, I think, more of a global education community thanks to the pandemic.
I wanted to close on a related topic, and that is social media. You've been on it for a decade, Twitter in particular, but I don't know, I truly don't know how big Twitter or social media are in the heme malignancy space. There seems to be pockets where it resonates more and has more of a network effect because, it's more gratifying when more of your colleagues are there. And so the lung cancer community is pretty strongly involved, pathologists largely, certainly a good number, but probably not the full range of breast and whatever. But I don't see a lot happening in the heme hashtag space, but that could be because I'm not following the heme world as closely. And so what's your sense of how helpful it's been both for education and for fostering a sense of a global community in heme malignancies, leukemia, et cetera?
It's really insightful. The hematology community is probably smaller than the solid tumor oncology community. So I wonder if that plays into it partially. I think there are different personalities to different specialties within hematology, heme malignancies, and solid tumor oncology. So you may have people who are more comfortable or outgoing in solid tumor oncology who are involved in social media. There are people who are very, very active and have been impactful. One of my besties is Navneet Majel, who headed up the transplant program at Cleveland Clinic. He's now moved to the Sarah Cannon Cancer Center at Blood Cancer Doc. He has an incredible following and has a lovely personality, both in person and on Twitter. And his personality really comes through. It's not only supportive of other people, but engaging in tweeting about current events and reacting to tweets. Vince Rajkumar has really come out on Twitter as being a huge force, not only, of course, in multiple myeloma, which is his specialty, but also in highlighting the international impact of COVID.
Yeah.
So he's been a great force. I think what I've seen over the past year and a half is social media platforms like Twitter have given us the opportunity to see our colleagues again and see little aspects of their life and kind of almost let us know that they're doing okay.
Yeah.
When I see, one of my besties from Cleveland is Nate Pinnell, who's in your field.
Right.
And I saw he went on a recent trip to Europe, and I got to see all the places that he traveled. And I had been wondering, especially since I left Cleveland, how he's been. And I got to see that a little bit. Or my colleague at Miami, Krishna Kamanduri, has a good following. And I saw recently that he bought a shirt that said, I see you're starting to laugh already because you've seen it. Do you want to, Charu, do you remember what it said?
Oh, I literally just saw it before this podcast. And didn't it say something to the effect of every every movie or every good movie about science starts with somebody ignoring a scientist. It's hilarious.
Every movie, every doom movie starts with someone ignoring advice from a scientist.
That's right. That's funny.
No, I love it. And, it's just that you get to know people. And I think it's been great, especially during the pandemic, because we haven't really had FaceTime, just to get to know people, to see what they're doing. And you're right that they're doing okay, that people are fine, is huge.
It's been, I don't know, for you two, you go through periods of depression during the whole pandemic, of just probably from not seeing people as much. We're social beings.
I got a dog. That's okay. Yeah.
What is it?
I got a dog. So yeah, a puppy cures all ills.
Okay.
But honestly, what I find myself thinking is one of the things that has always impressed me about medicine, oncology, and particularly with a lot of patients who are terminal, is it's amazing how adaptive we can be. As families, everyone, I'm truly impressed by how much people can adapt to adversity and the triumph of being able to sit up in bed and eat or something like that. It's sometimes quite inspiring to see how well people can adjust to the challenges thrown to them. I think that some of what we do can be really, really difficult for people, and for them to get their heads down and get through it is impressive.
Really nicely said.
Yeah.
This was a great conversation. Thank you so much for joining us, Mikkael. We truly enjoyed. I can't even believe the hour just went by. You can find us on iTunes or wherever you find your podcast content. We hope that you will subscribe and send us comments and feedback to beyondthejournalshow@gmail.com. We thank Mark Lindsay and Talking Speaker for production and distribution support. See you in a couple of weeks with our next guest.
Take care. Thank you.
Thank you for having me. Bye-bye.
Thank you.